Good morning. It's still morning.
It's still morning.
My name is Dr. Dean Waldman, and I have the honor and pleasure of moderating today's panel on women's health in Texas. Of course, we will be focusing on the issue of our pregnant Texans and maternal mortality and things related thereto. Please, I left this out here to remind everybody, turn off or mute your cell phones so that we won't interrupt our fine people. And let me introduce them. In order to avoid a charge of gender bias, I'm doing it in alphabetical order. It turns out, of course, that if I do that, that my colleague over there ends up being first, but no gender bias. It's alphabetical. It's alphabetical. Come on. All right. Dr. Radek Bukowski is a physician and professor at Dell Medical, as well as associate chair for investigation and discovery in women's health. Dell recruited him back to Texas after a stint at my alma mater. Before Yale, Dr. Bukowski, real Texan, spent 16 years at the University of Texas Galveston Medical and is an internationally known expert in maternal and fetal medicine. That's, for those of you who don't know, has become a unified field. We have finally recognized that mother and baby are one unit, then become two, but still are very close to each other. So fetal and maternal medicine. Leslie French is the Associate Commissioner in Power Pink of Health Development, Developmental and Independence Services Department within Texas Health and Human Services Commission. You're going to hear the initials HHSC, so understand what they are, Health and Human Services Commission. In her current role, Leslie manages 40 different health programs which serve clients from birth, and in fact before birth, to the end of life. Previously, she was the director of the HHSC Women's Health Services Division and the Office of Women's Health at the Department of State Health Services. Karen Harris, immediately to my left, is the vice chair for the Governor's Commission for Women. Before that, she was a gubernatorial appointee to the Health and Human Services Council. After earning an associate science degree in radiologic science from Virginia Commonwealth Medical College, she and her husband founded he's my colleague somewhere, and he's a real doc. He's, okay. MD. Founded a radiology medical service business in Texas that has been operating here now for over 25 years. Ms. Harris is the chaplain for Safe Harbor Compliance, founder of Medicine for Heart Ministries, actually rather important if you know what's going on the insurance end in Washington, and a prayer ministry team leader at Summit Worship Center. And I greatly appreciate her being here. And finally, saving the best for last, Representative Donna Howard has served the citizens of District 48 for the past 6 sessions. She is a member of the House Appropriations Committee, that little tiny thing with money, and serves as the vice chair of the powerful Calendars Committee. After receiving a bachelor's degree in nursing and a master's degree in health education from UT, she worked as a critical care nurse, like real doc, real nurse, in Breckenridge and Seton hospitals, and served as Austin's first hospital-based patient education coordinator. I think rather important. Representative Howard is past president of the Texas Nurses Association and was a health education instructor at UT. And I am very appreciative that these 4 wonderful people could be here today, and I'm sure you'll look forward to hearing what they have to say. Okay, so that's that. Can I have my first slide? Let's get started and think about something very obvious. In order to make a good decision about anything, maternal mortality or what you're going to eat for lunch, won't discuss what you're eating for lunch. you need good data. And so my question is to my colleagues, and I'm going to preface it with what's up on the slide. My question to my colleagues is the primary data on maternal mortality in Texas reliable? I ask this because of those three things up on the slide. Number one, the causes of death, at least in the data that we have seen published, were not based on autopsies. Now, I was also trained as a pathologist as well as a pediatric cardiologist, and the way you find cause of death is by autopsy, yet there was very little autopsy data to define cause of death in the women that are reported. Number two, the actual questionnaires that generated this woman was pregnant, this woman was not, that kind of thing, when she was pregnant and the cause of death, those questionnaires on the death certificates were constantly changing in the various states as well as here in Texas as well. So the data set was different from year to year. And thirdly, and I want to quote this because I teach biostatistics at medical school, from McDornand's 2016 article, Dr. Harris, quote, adjusted maternal mortality rates for Texas show only a modest increase from 2000 through 2010, that's 10 years. However, after 2010, the reported maternal mortality doubled within a 2-year period to levels not seen in other US states. Now, as a biostatistician, to have a statistic go from a very small increase to doubling in 2 years sounds concerning. We'll just say concerning. And at that point, I would love to hear Dr. Bukowski or anybody else answer the question, what about the primary data? We're going to get to what it means, but my first question is reliability.
So I think I would like to show a couple of slides as well, just because I think it's easy, or easier just to see it as it appeared in this article. So this article was published in 2016. There is actually another one that came last month from here from Texas that reviewed essentially specifically the increase of specific cases that occurred in 2012. That was the year when we have seen suddenly doubling of maternal mortality in Texas, so basically from rate of about 18, 19 per 100,000 live births, and this is how it's measured. It suddenly increased, almost doubled, and that was obviously very concerning, as Dr. Waldman just said. And if you can show how it looked, essentially what they did, they showed several of those different, they divided states in different groups, and they show how their rate of maternal mortality changed between 2000 and 2014. And if you can show the next one, they all essentially showed the same thing. They grouped them states based on the fact when did they and did they include the question on pregnancy in their death certificates. And if you go to the next slide, you can see that this is group actually 3 and 4 when they showed states that either did not change anything in their questions over this entire period of time from 2000 to 2014. They basically use the same form, so to speak. And then the other one is the group which had the similar question already before. So even in states that they didn't change anything in the form that the death certificates are used, all of this essentially show the same thing, that there is a slow, steady increase in the rate of maternal mortality. And if you go now to the next one, there were 2 states that could be analyzed separately, and you can probably guess which states they are. The most populous ones, and there was California and Texas. This is a rate in California. California basically did not have a question about pregnancy on their death certificates until 2003. So you can see the rates were very low. And then when they introduced the question, the rate went up. And the rate is actually much higher than other states because California decided to change, but change to something different. Essentially, you can measure maternal mortality by saying if death occurred within 42 days of pregnancy, 6 weeks, or did it occur within 1 year. California decided to do it within 1 year. And a lot of problems with this data is exactly for 2 reasons. One, the different definitions have been used. and they have been used also and introduced at a different time in different states. So it's very difficult to analyze this data. And if you go to the next one, this is Texas. And Texas basically in 2006 introduced this standard data form from or question on pregnancy, on death certificates. And you can, I made a little red arrow. The red arrow shows essentially when this form has been introduced. As you can see, really the slope didn't show any significant changes there. And then suddenly in 2010, you can see that the line goes up a lot. And this was left in this conclusion of that paper as unexplained, surprising. I think as we just heard a moment ago, this is not something that one would normally expect. This is something that would be consistent with some natural disasters, but not, not just a sudden change. So there had to be something wrong with this. And then if you go to the next one, there's this paper from last month, which basically showed that if you do a careful recounting and go deeply into trying to find out if the reports that have been done on those certificates, if you go into the things like hospital discharge records, medical records, and you start looking at those, and then they actually will be found out that the rate in 2012, which was this high increase, was actually much, much lower. It was only about 14.6, so even less than that. And then the next slide will show you that there were some cases that were not accounted for. It couldn't be told, actually, even after very careful investigation, if they are related to pregnancy or not. So even with those who account them being related to pregnancy, it's still around 18.6, so not this dramatic increase. And then the next slide will show you exactly the numbers. So the initial calculations were based on 146 maternal deaths occurring in 2012 in state of Texas. After looking carefully in those, that was found that only 56 were really related to pregnancy, and 71, if one includes the 15 that could not be accounted for. So this is essentially how, I think, illustrates how does it look. I think the message was that there is some increase in different states. However, those numbers are very difficult to, there was some essentially difficult to interpret those increases. And I think that was something that probably many people expected.
Representative Howard?
Could I have my slide up, please, as well? Thank you. Clearly, this is a great example of why we do need to look at something when we get an aberration like this. It was very alarming, of course, to people to see the report come out. One of the tasks of the task force looking at maternal morbidity and mortality was to look at what the heck is going on here so we could try to figure it out and address it. Within their deep dive, as Dr. Bukowski points out, in the review of the actual charts and records, it was discovered that there were errors in reporting, errors in the use of the death certificate itself, that the way it was set up apparently contributed to some more human error occurring, and revealed that there was over-reporting and under-reporting. Revealed, as you can see on this chart, that there were certainly, and this is over a 4-year period, this is the latest information that I got from Health and Human Services, but reveals on this chart the different types of deaths that were looked at and over a period of time, and as you also just heard, the cutoff point to meet the World Health Organization methodology is 6 weeks or 42 days. What had been looked at also included deaths beyond 42 days. So if you died on day 43, you shouldn't be counted if we're going to have a pure apples to apples comparison. I think, and we're going to talk about where we go with this, I think the takeaway that we got from this is that, thank goodness, it's not as bad as it looked. And that there are ways we maybe can still look at how to address this. One we already did this last legislative session, which had to do with changing the death certificate so that it was more going to be more accurate reflection. But the point of my bringing up this slide is what you're looking at here, a lot of these are preventable deaths. And regardless of whether it's 14 to 18 per 100,000 or 30-something per 100,000, these are your mothers, your sisters, your daughters.
Absolutely.
Right.
These are, many of them are preventable deaths. We still fall, now we have probably inconsistencies throughout the United States in terms of the other states and how they're collecting their data. But looking at what we currently know, we still fall probably about in the middle of that.
Mm-hmm.
So we still have room to improve. There are things we need to address. What this chart shows you is that there are a certain number of deaths up through those first 6 weeks. There's a significantly larger number within 1 year, and both the American College of Obstetricians and Gynecologists, as well as the Centers for Disease Control, have been recommending for quite a while that we look at the whole year, because there are pregnancy-related deaths that occur after day 42. So if we really want to address this, we need to look at the bigger picture here. Recognize that, yes, the data was not accurate, not because of faulty methods necessarily, but because we had inaccurate data in the way that it was reported. We can correct that, we can move on, we can look at what's going on here, and then continue to deep dive and find out what the real challenges are here and how we keep these women alive. And that's what this is about.
Anything to add, Leslie or Karen?
Well, I'll say, in the main, I think the main point is that, one death is one death too many.
Right.
And one death in...
One preventable death is one death.
And you have 82 women that didn't get to hold their baby, didn't get to watch it grow up, missed out on all those opportunities. And what we're seeing based on this data, that most of these are preventable deaths.
Yes.
We can take preventable measures and actions to really be able to make a difference and help women have healthy outcomes in birth, as well as healthy baby outcomes as well. And so I think that the main thing that we've really looked at, done a really deep dive, and the dive that DSHS has done on this data has been tremendous. It's literally, they have pulled every single death file, matched it with the primary care file, with the OB-GYN file, with every other information that they can get their hands on with HIPAA, to be able to go into what happened in this situation, what caused this woman's death, what can we learn? And I think a lot of things that we've learned, to what Representative Howard just stated, is that 56% of all these deaths occur after the 42-day period, which means those are things that we, as the public, can really help with, whether it's cardiac arrest, it's drug overdose, if it's hemorrhage or hypertension. Substance abuse is a very high contributing factor to maternal mortality, but so is postpartum depression. And so having these conversations and saying, okay, we've looked at this data, we know that the data is better, it's at 56, it's not 147, it's at 56 now, but that's still 56 deaths too many. And so as we're going through this, saying, okay, what is the contributing factor, and what is happening, and what can we do at the state level, both through education, both through improvements in our different programs, to really help mothers and babies have healthy lives.
Anything to add, Karen, or should we?
Well, I think that this panel today, I perhaps bring a little bit of a different perspective, in that I'm not actually working in the data. As a woman on the Governor's Commission for Women, I am a liaison between the Governor's office and the women in the community. And I actually had a phone call right before I came here today. And one of the things that I want to share most with you in the room today has to do with those things that are difficult to measure, those things that impact communities on a daily basis, things like postpartum depression, not having a strong infrastructure. We have a very fractured family infrastructure, which contributes to the health or the unhealthy position that a mother finds herself in. Those things are those things that we can't quantify very easily, but we would be remiss in our duty in our conversation here today if we did not at least acknowledge
Recognize,
those things.
yes.
The conversation that I had before I came had to do with an organization here, right here in Austin, I'm proud to say, an organization that provides those kinds of services to women in the community. The study also touched on the disparity between the number of women of color that are affected by this.
Mm-hmm.
Any woman, black, white, blue, or purple, this is an important thing for us to thrash out and see if we can't
Sure.
come together and find out what's going on. But as a black woman myself, that's obvious, it is important to me when I go into the community when they say, well, Karen, what are we going to do about this? What can we do about this? And this is what I hear, because I'm kind of boots on the ground in the community. And the conversation I had with a young woman this morning had to do with volunteerism, which has been one of the things that the governor has tasked the Women's Commission to help him increase in the state of Texas. When volunteers go into their own communities and they're able to sit and speak with these women that are afraid because their family is fractured, or they're a single mother, or the husband is working 2 jobs and the mother is caring for other children. All of these life stresses impact the pregnancy, and the childbearing families in our communities feel this. So one of the things that the governor has tasked our commission with is increasing volunteerism in the community. As a volunteer, you can go into that community and smile and sit and talk or pray with a young woman, and that can help get her through a really bad time. And I think that, again, we would be remiss in our duty here today if we did not mention those kinds of things and the importance that they bear in a family's life. If we have healthy mothers, we have healthy babies, healthy mothers and babies, healthy families, and we have a healthy Texas.
Amen.
May I add one thing, please?
Please.
Based on what Karen said, and thank you for what you just shared. The other thing I think is important to recognize about the 2 different studies in the data is that both of them still reveal a disproportionate impact on African American women in particular. And so regardless of whether it's this number or this number,
Yes.
the fact is that those mothers are disproportionately impacted, and we need to determine why that is and address that as well.
Before we go on, I did want to share something that Leslie reminded me of. I probably suspect I'm the oldest person in the room, and I come from a long medical family, and I remember my father, uncle, and my grandfather was the chief of staff of the hospital, essentially screaming at each other over what was discussed at the death committee. In the back in the 40s, 50s, into the 60s, and then the lawyers took over. Prior to that, there was a death committee, and every woman, for example, who died, pregnant, not pregnant, whatever, a death in the hospital demanded a full death committee analysis. What could have we preempted? What could have we done differently? And there's a claim that that still goes on today, but telling you reality, it doesn't. The hospital prevents the doctors, even though it's confidential, from saying certain things like, I made a mistake, okay? You never say that. But back in the old days in the death committee, you're damn right, forgive me, but anyway, let's move on. Given the fact that the data is, let's just say, soft, but the fact is we can all agree that there is a problem. We can have debates about the magnitude of the problem. I don't think there's any question about the disproportionality that Representative Howard just brought up. The data for that is so overwhelming that I don't think you can debate it. Now, so my next question is, given the data we have, what can we conclude from that data, or at least infer from that data, as to root causes? I mean, it's one thing to say preventable mortality. What caused that we can maybe do something about to preempt in the future? Anybody want to start?
Well, and I'll say with the slide that is up right now, I mean, you can see the different causes of death. And some of them may not be preventable, but some of them, most of them really are. Most of them, if you are in early prenatal care, early prenatal entry to care is so important. And that's something that I think, going to Karen's point, really having that discussion and that education within our communities to say, you know, if you're pregnant, it's a great thing, but you need to go to the doctor and make sure everything's going well. Like, go to the doctor at 6 weeks, go to the doctor at 8 weeks, make sure you're taking your prenatal vitamins. Have those conversations to be able to, if there is an issue, if you have early gestational diabetes, or if some women have hypertension issues that develop during pregnancy, we can catch those early and we can have a course of action to really help maintain the health of the mom and the baby through her pregnancy, so that when she is delivering in the hospital, everyone who is part of her medical team knows what her history is, knows what has happened over the course of her pregnancy. You know, what are things that we need to look out for? And having those conversations ahead of the birth is so vital. And I think what we've seen in a lot of the data, and what we're hearing, especially in our communities, I visit with providers and clients across the state. We hear that a lot of them say, well, I don't need to go to the doctor until the baby's here. Like, I'll just go when my water breaks, I'll go to the doctor. I don't need to go to the doctor beforehand. And then when they do present, we're finding high rates of gestational diabetes, high rates of hypertension, and that makes the birth experience that more dangerous, actually.
You know, as a pediatric cardiologist, I will tell you, because I'm on the receiving end of these babies, when you look at the history of medicine over the last, say, 50 years, one of the major advances, which nobody seems to talk about, is simply prenatal nutrition and education. What to avoid, what over-the-counter medicines to avoid, which could potentially harm your baby. There are millions of people, and I fear hundreds of thousands of Texans, who don't understand you don't take aspirin late in your pregnancy. It is bad for your baby. So forgive me, I'm on my soapbox. I'll get off my soapbox.
I think that speaks again to hands-on and just caring in our
Yes.
community. It is surprising that young women do not have the educational tools to help them have a healthy baby.
Right.
One of the things that has come to my attention as I'm talking with women in the community and helping to encourage other people to be involved in the community and volunteerism, and talking to nurses and that type of thing, birth coaches. Childbirth is supposed to be a natural process. And look, today, make no bones about it, I am here today to receive information, probably more than I am to give information, because of just who I am as a person and my role as the vice chair of the commission. So one of the things that we have been talking about has to do with childbirth being a natural process. But in the United States, we have turned it into something
A medical
else.
illness.
We've turned it into something else.
Yes.
And that is something that I have not seen addressed at all in the study, and we seldom talk about it. I am delighted to know that we have organizations, even here in Austin, that are now saying, you know, this is not a process to be afraid of. And this is how we do it. And let me help you, walk through this process. It's not supposed to be scary. So on one hand, that is a great thing. Not on one hand, it is a great thing. One of the most disturbing things that I've read has to do with the numbers, Senator Howard. It really disturbs me. The good news, the good news is we don't have as much of a problem in Texas as we thought. That's the good news.
Right.
The bad news,
Is we still have a problem.
we have a problem.
Yeah.
And the really bad news is we have a problem compared to the rest of the people on the globe. I read one article that compares us to Afghanistan and Sudan. That is something that should cause all of us to shudder in this room. That our maternal morbidity and our mortality rate in the United States in general is one that can be compared to those two places. That's pretty scary to me.
Speaking of prevention, Dr. Rutkowski,
Yeah.
please.
You know,
Root causes prevention.
Exactly. I think this is probably the most important part, actually. I don't know if you are the oldest person here. I think me. So I have been practicing for about 30 years, and in different countries, different continents. And I think that there is definitely a problem. It's horrible. I mean, it happened to me twice, that I had maternal death, and this is it's essentially impossible to explain how does it affect everybody, and it's not. It's for family, for physicians, for nurses, for everybody in the hospital. It's absolutely horrible. I think that I put those numbers because I think it's important, to kind of be anchored into what the facts are. But the reality is, regardless what those numbers are, it's pretty clear that our rates are increasing. Obviously, there can be some ascertainment problem that we are counting better, so to speak, or maybe they're counting better in California. However, the issue is that we are, regardless how we do it, we rank 46 out of almost 200 countries in maternal mortality. This really should not happen in developed country, and especially not country like the United States. But counting is one part of it. The other part, which may be even more important, is that counting is essentially not going to save lives. It's going to focus the attention on things. But really, what we have an advantage of changing something is looking at prediction. Who has high risk of dying, and then prevention in those individuals. Why? Because yes, we know that there is what are the leading causes of maternal death. However, the issue is that vast majority of women, for example, who have a hemorrhage, either before or during or immediately after labor, they don't die. Vast majority are completely fine, and we can do it. But there are some individuals who do, and that is what would be really important, is to identify who actually is at that increased risk. Who are those people who can help? The other issue is, other part is what we just heard. That African American women have a staggeringly increased risk of having maternal mortality, and the estimates are approximately 3.7 times. This is really not something that could be just happened by chance. There is something very, very serious to consider. However, the positive thing, because I think we have to end on a positive note,
Please.
is that this is if there is a place where things can change, that's always what I think about after being here for 25 years. America has amazing ability to change things. Mm-hmm. And if you don't believe me, go to Europe and look, for example, at in airport and all these places where people smoke. You go to restaurants, and I'm sure the people who are a little bit older remember that in this country, the smoking was very prevalent. There's doctors' advertisement, doctors smoke Camels and other things, and it changed within an amazingly quick period of time. It may not be doable in other countries, but it's definitely doable here.
There's several things that I want to respond to here based on what others have said. Speaking of the natural nature of childbirth, I come from growing up in the 60s and 70s, and certainly we were into natural. and a lot of my friends actually had home births. As a nurse, when I was having my first child, I wanted it to be a natural process. I recognized it as that. I wanted little medical intervention, but I also chose to be in a hospital in case anything went wrong. And sure enough, I'm one of those that hemorrhaged. And I ended up getting 4 units of blood, totally, unconscious, with my husband luckily there, because we had the fathers involved, and he was taking care of the baby. It turned out to be wonderful. I survived. I'm okay. But there are those, as he points out, that have the same thing happen to them. If they're not being taken care of, it's not being addressed appropriately, they end up being one of those statistics. But I think talking about the prevention and what happens during your prenatal time is extremely important. Obviously, we've been hearing. And we know that a large number of births in this state are unplanned. And by just the virtue of the fact that they're unplanned, many women are not accessing prenatal care early in their pregnancy, and that has an impact on the outcomes. We know that the deaths, according to the report, primarily are occurring among African American women, women on Medicaid, teenagers, women over 40. Those are kind of our higher risk areas. When you're talking about women who do not have insurance, do not have a medical home, find themselves pregnant, they can finally get onto Medicaid. They may be further down the road in that pregnancy by the time they do. And then the way our system is set up, 2 months after delivery, they're off Medicaid. Now, Leslie can tell you she's been trying very hard to have a continuous care option where people are re-enrolled in other programs that they do qualify for, but we have not gotten where we need to get with that. So when you have this discontinuity of care over time, entering the system, as one doctor told me, I can't correct in 9 months a lifetime of ill health. A woman's coming in and you're trying to do the best you can to get them in the healthiest position for having that baby. But once the delivery occurs, too, another thing I've heard is that the baby's the candy, the mother's the wrapper. Not the wrapper, but the wrapper of the candy. The wrapper's discarded, and not literally necessarily, but the focus has been very much on the baby with little attention to the mother. There was another panel recently that occurred where one of my colleagues who's been very actively involved in this was speaking. She talked about her own delivery and the fact that as an educated woman, a lawyer, after she delivered her baby, she didn't do a postpartum visit because she didn't know she needed to. This is an educated person. This is not just about people who don't know.
That's right.
There's a lot of factors here that we need to figure out why this is happening, because it is the preventable, we've been talking about the specific preventable diseases here. If you have developed hypertension, eclampsia, gestational diabetes, all kinds of things that need to be monitored, and you're not getting that attention, then you do fall into a category that whether or not you're a death statistic, we have significantly higher morbidity attached to this, 50 times what it is for mortality. So regardless, there can still be long-term health consequences to not addressing what's going on here, even if the death itself doesn't occur.
I'm going to tell you a little quickie story and see how people will respond. Speaking of prevention, which is obviously what we want to do, is not treat things. We treat what we have to, but we don't want to prevent them, preempt them. When my first child was born 46 years ago, healthy woman, term delivery, my wife is a healthy person, baby came out at 8 pounds, 15 ounces, huge baby, no gestational diabetes. And she didn't breathe, and I had to resuscitate her, okay? Possibly the worst experience of my life. But, it was really great. I resuscitated. I didn't realize she was my baby. I said, this is what you do. You intubate the baby, suck him out. You just do the things that you're trained to do. Of course, afterwards, I got the shakes. Now, so 5 years later, my wife is pregnant again, and we're delivering a child, and this child's even bigger. And so I had the joke around the hospital. I was the chief of cardiology, so I could kind of do whatever the hell I wanted. I had that delivery room ready to triage a train wreck. Okay? Okay. I had every size and shape of intubation tube. I had 2 suction units, not one, because one might fail, et cetera, et cetera. And of course, the kid came out with an APGAR score of 13, the highest is 10. The point of the story is this: I didn't realize that I had created a baby crash cart. Now, everybody knows that every hospital has got a crash cart for somebody who might have a cardiac arrest, and you're going to try and resuscitate them, and you need oxygen, you need paddles, and you need all the things you think you need, the various drugs. I created a baby crash cart. I didn't realize, but I created a baby crash cart. Here's my question: why don't we have routinely maternal, especially I'm thinking about bleeding, maternal crash carts?
Well, I'll say that I think that's what we're developing right now
Okay.
at the Health and Human Services Commission. So DSHS they're the ones with the Maternal Mortality Task Force, and so they've been diving deep into the data and finding all these new.
You're leading into where I'm going, so please keep going.
New information of like, okay, how can we improve? What is the education that we need to do? What else can we, we're being responsive to the legislature and making sure that we're looking at the entire spectrum. And one of the things that we've realized is that we don't have what's called maternal levels, the bundles of maternal levels of care at our hospitals. And so we're one of the states that has joined the new AIM collaborative, which is a national collaborative looking at maternal mortality issues and saying, okay, what can we do to prevent maternal mortality? And so a lot of, there's several states who have been in this collaboration for a couple of years, and they've implemented what's called a hemorrhage bundle, a hypertension bundle, and a couple other bundles. And so what it is, it's developing protocols in the hospital saying, okay, if a woman is presenting X, Y, and Z symptom, we follow this protocol and we give her, if she's hemorrhaging, more blood. Then we may have been trained a certain way, but now the evidence is showing that we need to add additional blood. So we are going to be implementing the new AIM bundles in Texas. We're very excited about this because we think this is a very positive development for Texas. It's really going to show a decrease in maternal deaths over time because every state that has implemented this has shown a decrease in maternal deaths. So we believe that this is part of the answer. We just put in new rules in place for maternal levels of care, which is a hospital designation to say these are the different protocols that I will follow. This is the different options I will have within my hospital to be able to respond to any kind of maternal crisis that may develop during pregnancy and during birth. And so I think there's a lot of things that are really happening right now, both at DSHS and HHSC, to say, okay, we recognize we have a problem, and we're going to do everything we can to, bring our communities together and say we're going to take this head on. We're going to educate our family members. We're going to educate our physicians, our doctors, our social workers, community health workers, and all of our different partners within the birth experience to say we're all in this together because nobody wants a mom to die. Nobody does. And so let's take the best evidence that we've seen from other states and implement it in Texas and see if that can make a difference.
I was going to go to you right now, so I want people to understand that 2016 article came out and it was touted as though this is a new finding. Gee, we didn't know that there was a problem, and look, we are terrible here in Texas. We are double what we used to be and double what anybody else is, and this is a new event. And I met with Leslie 2-3 months after that article came out, and very calmly she says, oh no, we've known about the issue. I don't want to call it a problem. Let's say the issue for years. We have been working on it here in Texas. This is not something new. And so I was going to use that as a lead-in, but I want you, is there anything else you want to add as to what, we're going to ask in a minute about what we can do going forward, but I'm curious to what has been put in place so far.
So I think a great, when we noticed this trend in 2012, and as a result, the 2013 legislature created the Maternal Mortality Task Force. And so we started studying the—
In what year?
2013.
Thank you.
And so we started studying that, and it's been an ongoing process. I mean, it's a tremendous amount of work to study one individual cause of death. And you don't want to just look at what happened in the hospital. You want to look at, well, were there factors leading in before
Yes.
the birth occurred? And so the amount of paperwork and getting the lawyers involved for all the HIPAA compliance too, I mean, it's an amazing amount of work that the task force does. And the task force is made up of doctors across the state. So it's doctors who have volunteered their time to come in and study every single death that has occurred. And I mean, it's heart-wrenching, that amount of time looking at this and saying, okay, what interventions can we learn? What can we glean from this information to really help make a difference in prevented death in the future? So I mean, it really the direction of the legislature, the support of the legislature, not only on maternal mortality issues, but also on improving women's health, improving child health, and really the resources that have been dedicated and making sure that our programs are being responsive to the new scientific data that we're discovering, the new lessons learned that we see from the Maternal Mortality Task Force, and other things. So I think there is a amazing partnership, and it's not just the state agencies. We have quite an amazing partnership with providers, with community activists, with stakeholders across the state who are coming together, just like what Karen said, and said, let's take this on, because this is our community, and we don't want a mom dying. We don't want a child not growing up with the best nutrition. And so it's really a network that's coming together to say, okay, if it is a mom that's coming into my clinic, has she had a prenatal care? Is she enrolled in our service? Is she enrolled in Medicaid? If she's not in Medicaid yet, we can get her into the Title V program as a subsidy while she's waiting to be enrolled in Medicaid. Maybe she's not eligible for Medicaid, but she can be enrolled in CHIP perinatal. Okay, let's enroll her there. How can we get her connected? And then what are the social supports that we can offer this woman as well? Whether it is our different community groups, whether it's the educational community, whether it is our faith-based community that's coming together and saying, we're gonna help this woman as she's going through this process. Because the majority of pregnancies, as what Representative Howard said earlier, are unplanned. And if a woman is in an unplanned pregnancy, that means she needs more help, not less. We need to be able to be there for her, give her the materials, the education that she needs, making sure that she is enrolled in great healthcare services, and that she has like a navigator, somebody that's going to walk alongside her to help her through this pregnancy. And then not abandon her once the pregnancy is over, but continuing by her as she raises a kid. Because I know a lot of you here are probably parents. Parenting is the hardest job in the world. And we need, and as you've seen on this data, 56% of the women who die between day 43 and day 365, which means they need help then. And they need to make sure that they're enrolled in the programs that the state offers, if they're qualified, or if other different options that exist. But really saying, let's as Texans stand up for our Texas women and say, let's bring our communities together and be the answer to this problem. Because there's not a single mom that should die. One death is preventable, and we can do better.
I don't like to bring up the idea of the principle of money, but I think there's one that I want to bring up that you just touched on in my head that I think we really need to think about. If you think about the cost of one premature baby who could have been kept in utero with proper prenatal care and good nutrition and good follow-up and so forth, the cost of the additional care that prevented the premature birth is much less than the cost of treating, especially a very premature baby where you're going to have ongoing costs for years and years. And we don't talk at all about avoided cost in healthcare because everybody's looking at next year's budget without thinking about anything that's long-term. And this is just me making this point, but I think the premature babies are a great example. If you can get more people involved, whether it's volunteers or it's state workers, I don't care, but more involved with the women so that they have good nutrition, so that they actually get their follow-ups early and continuously, you're going to have fewer premature babies, which means we're going to spend less money.
Oh, I think actually we have talked about cost avoidance, and certainly we've looked at that in terms of the unplanned pregnancies and the cost incurred to the taxpayer with the Medicaid expenses when we are looking at our family planning programs, and whether or not we need to do more there to ensure that women and their families have the options they need to avoid the unplanned pregnancy. And we do actually have dollars that have been applied to that to show the cost, the savings
Good.
that we have realized by giving these families access to contraceptive and reproductive health care.
And there was a new report that was just released late last week that shows the cost of the investment that the legislature made with the launch of the Healthy Texas Women program and the family planning program really does save millions of dollars for the Medicaid birth costs.
Let me go right now to sort of the future question, which is, what are we thinking about now that we need to do in the future? I'm sort of aiming this both at my colleague on the end as well as Representative Howard. You know, okay, HHSC is already working on stuff for that they know, that we think we know. But what's left undone? What should we think about doing?
You want to start?
Yeah, happy to. This is really fascinating. I think I am very thankful that that you invited me to participate in this thing, because whatever our panel, and to see that there's that many people are actually very interested in it and would like to help, because I think that we have a unique opportunity now to move things forward. We actually are doing quite a bit at the moment. There are so-called trigger mechanism for and managements for the main causes of maternal mortality. The hospitals have these massive transfusion protocols, the pregnancy transfusion protocols. Essentially, just one push of a button, and then the whole cascade starts. The blood products and people being there. There are rapid response teams, that are available for baby and for the mom. Actually, other way around. And the sepsis protocols, check-off lists and other things. So a lot is done. But maternal mortality is something that is very, very complex. And I think we probably don't appreciate it, how complex it is. Mm-hmm. And one of the important part is to remember this is death. So many, many things can cause that. And we are, human beings is the most complex system that exists. Complex systems are things that are made of many, many things that interact with each other in very complex ways. The result of that is that we very rarely are going to have a root cause, the one cause that resulted in a death. Most of the time, those systems have something called causative pathways or networks. Many things come together and somebody, and that results in something so terrible like maternal death. And it really is terrible, because May 3rd, which is tomorrow, is the one thing that I really don't like the date, because one of this maternal death of the two happened on May 3rd, and every time May 3rd comes, I always feel uneasy, and I don't like to be on labor and delivery on that day. So it has a tremendous effect. I think what we have the opportunity is not only to follow, but we have now opportunity to really actually lead this change. How? This maternal mortality is very rare, right? It's maybe 20 per 100,000 live births. This thing, to study such rare occurrences is very, very difficult. Very difficult. You can just see very easily why did 2 states only have been analyzed individually. Everybody else had to be bunched together, because it's not enough data to look at this in other states. And it's very difficult to pinpoint, because in this individual case, each individual death have happened probably in very different way, in different circumstances. So it's very difficult then to come with something, say, oh, this is how we should do it. However, there are methodologies and methods that can help that. They're related to advances in data science, in computing, and mathematics, mathematical modeling, this kind of things. It's used for others outside medicine. And actually, University of Texas here in Austin is one of the leaders. We are home of the institute that is ranked #1 in applied mathematics and exactly this kind of things, interdisciplinary in the world. We have the largest supercomputer in public hands in the world here as well. This is like we ideally poised, to take it forward and not just follow others, but actually do something else. There are people who do here things which are amazing. It's a grant application, National Science Foundation, coming specifically about that, how to monitor women in labor using those remote, I call them ETA tools, that I thought that would be very good for Austin. They're basically a monitoring devices that you can measure mom's blood pressure, pulse, hydration, her AKG, EEG, and other things remotely. So the things are being done here, and we actually may have a good opportunity by engaging, I think, academia in this, and moving things forward, and maybe having some real, we leverage essentially what's happening here. And the scientists here, not only the doctors, but also the people who are outside, and we have these multidisciplinary groups are very interested in engaging in this kind of relationships. So prediction, prevention, using novel methods, looking at this a little bit different way.
Before I let Representative Howard have the last word, I want to say something that you touched on, Dr. Bukowski, which is there are whole multiple sciences of failure prevention in other bad outcome prevention. I'm trying to be very general and broad as I can. I'm thinking specifically of the airline industry, of metallurgy, where they're learning how to pre-diagnose, if you will, like pre-crime, if you're a movie buff, pre-diagnose the stress, fractures, airplane checklists. Nobody's going to get on an airplane without these were developed by analyzing failures, as in bad outcomes, and learning how they occurred. And that's my point, is that we have the capability by translating other technologies, mostly mathematical technologies, and telemetry and so forth, to prevent. Go ahead, Representative Howard.
Well, thank you. Yes, absolutely. And at the legislature, of course, one of the things that we are doing is continuing the maternal morbidity and mortality task force. Remember that this has only been 1 year that's been looked at this point. So we don't really still know a lot of what's going on, and the task force is continuing. It's expanded its scope a bit, also getting a lot of assistance at getting the charts more rapidly than they were before. So they anticipate getting through a couple of more years worth, perhaps, by the end of next year. It's a slow process, as Leslie was saying a while ago, but it's going to give us more information, so we're going to continue that. Certainly the American College of Obstetrics and Obstetricians and Gynecologists has also recommended things such as what Leslie mentioned, the safety bundles, which THA, the Hospital Association, and others are working on making sure we look at implementing in our state. In addition to that, what's been pointed out by ACOG is, as I mentioned earlier, wanting to look at this for a whole year as opposed to just the first 6 weeks postpartum. There are obstacles to that in terms of reimbursements and how our system is set up, so that if a woman is in the package only gets one postpartum visit, that really may not be the right way to do this. We need to look at what's the best intervention and level of care that woman needs, and not just limit it based on some arbitrary one postpartum visit. And then certainly one of the things that a lot of us are looking at, and again, working with Leslie and what she's been trying to do, is how do we get continuous coverage of care for women? There are those that are proposing that we extend Medicaid coverage beyond just 2 months postpartum and make it for a year postpartum. I myself would love to see us go even further and have continuous coverage for all the perinatal years for women of childbearing age, because we do not know with these unplanned pregnancies when the pregnancy will occur. The kind of care that's needed, as I said earlier, is not going to just change in 9 months either. They need to have the continuity of care postpartum, absolutely. Clearly, we see in the chart that there are the mortality issues, as I mentioned, 50 times that for morbidity that needs to be covered. So continuous coverage is going to be one of the biggest challenges we're going to be looking at, I think, at the legislature. How do we help make that happen? Because access to care is one of the main things that the task force has already told us is a recommendation of what they're seeing we can do to address this and prevent some of these preventable deaths.
Thank you very much. I would now like to really ask for, if you will, dialogue, namely the Q&A. Please feel free. We have microphones right here. Come up and ask whatever you like. Appreciate a little succinctness, which is something I'm very bad at. Sir.
Thank you, and thank all of you. One thing that wasn't discussed is, I guess, we're in year 5 of the Affordable Care Act. Has there been any data showing the difference between women in states that have expanded Medicaid and those that have not, and how that might affect what we're talking about here?
Does anyone have any knowledge? I do not.
Well, all I can say is my understanding is that the implementation of the safety bundles in California occurred before the expansion, the Medicaid expansion. So there was already a drop occurring because of the implementation of the safety bundles. That being said, you know, I don't know that there's a comparison between the states, you might know, Leslie, that have or have not expanded. Certainly access to care is an issue. And so one would just hypothesize that would be a factor. But I don't know that there's any specific data on it.
I'm not aware of any data or studies specifically on that question.
I will tell you one thing that at least I'm a little worried about. I don't know of any data that directly answers your question, but I can indirectly answer it, and that is several states, one close to us, New Mexico, expanded Medicaid, and as a result of the shortfall in their budget, ended up reducing reimbursements to physicians, which in turn reduced access to care. I worry that might occur to our pregnant women, that they could get on expanded Medicaid and have actually less access to a physician. I'm not saying that's true. I know it's true in other states. I cannot comment on Texas.
Well, let me just say about that. Certainly, that's a challenge we have all the time with providing health services. If we change a program and change eligibility to get more people in, but then reduce the amount per patient or the reimbursement rate, then we are not necessarily addressing the issue. So that's something we've been dealing with for a long time.
I actually have 3 questions.
Closer.
I actually have 3 questions, but I promise they're quick. The first one is based on the Baeva study. They cited 147 maternal deaths within 2012, but I was wondering, there's a bit of a discrepancy in the data that I found, because I looked at DISH's data and there was only 121 maternal deaths. And then on the chart above, if you combine the while pregnant 0 to 7 days postpartum, 8 to 42, there's only 144. So I was wondering if any of you could speak to the discrepancy between those 3 sources of deaths.
I can take it. I'll take it. We'll see. The 147 was all deaths that had been reported for 2012. In it was coded women over the age of 65 as being pregnant, men who were pregnant, and others who under the age of 11 that we found out were not. So the 147 was an incorrect number all along. When we pulled all the files and everything and narrowed it down, that's where we came up with the 56 confirmed maternal deaths that did occur in 2012. And the slide that's behind us is actually for a 4-year period, so 2012, 13,
Right.
14, and 15. So that slide is a 4-year period, not just 2012.
Right. That's one of the things that I was asking was because in the dishes data there was also like 121 instead of 147. How like
And some of that is because of the incorrect coding of pregnant men.
and then as far as that goes, it has been attributed through that study to mistake or human error as the big jump. But the U.S. The change in the Texas question in 2006
Questionnaire.
to the U.S. standard question about pregnancy was in 2006. So why did the jump not happen until 2010 and 2012?
I'm happy to answer. If you could just show my secret slide, the last one.
Not a secret anymore.
Secret slide.
It was not set up, no. We never met.
You'll get your check in the mail.
No, actually, I just put it in because I thought it was, I had the same thought, it was
Right.
really fascinating. So if you look at the last slide, in essence, in this study from last month, what was suggested, and again, remember, this is only correlations, this is not causation. We have so often have this tendency to find out, oh, this caused it, this is the reason. We really don't know. There is thousands of things that correlate just by chance, especially if you look at a lot of things. So one of the things that article was quoting is that, yes, in 2006, there was introduction of a new standardized method of identifying pregnancies on the certificates in the state of Texas. However, then afterwards, there was introduced the electronic format of recording the relation to pregnancy in those deaths.
What year did the electronic
So
change?
these two numbers that are here, you can see that between 2010 and 2012, the use of electronic format, basically skyrocketed. And one of the suggestions in that paper which was interesting, is that that the parts which say not related to pregnancy and pregnancy within 1 year are actually next to each other in this drop-down menu, which could have been, again, I just want to emphasize, this is just only correlations and maybe a reason, but there could be something else.
Thank you so much.
So I think that this could be an explanation, although we probably don't know.
Okay. And then my third and final question, I promise. If the 1115 waiver to gain more funds for the Healthy Texas Women program gets through, is there any talk around expanding to SUD services within Healthy Texas Women because Medicaid expansion is so kind of taboo right now?
So I think that's just a question for the legislature, because we'll want to make sure, so we applied
Yes.
for federal funds for
Right.
Healthy
Pass the
Texas
ball.
Women.
Pass the
And
ball.
depending upon, what is the end result from that, any kind of additional benefits that we need to add, and maybe we do need to add some additional ones based on the findings of the task force, but we'll defer to the legislature for that decision.
Certainly, the legislature, a lot of us at the legislature want to make sure that we have a program that is going to be successful, and we want to expand whatever we can here. And need to remember that we've gone through many iterations over the past several sessions, beginning with the 2011 budget cuts that occurred. So we've had to continue to look at what's the most effective way to do this with the variety of approaches that we've taken. We still don't have comparable data right now to tell us for sure where we are. We don't think from what we're looking at that we're even seeing the same number of clients yet that we saw prior to the 2011 cuts, but that's the kind of thing that we're working on here. We destroyed a safety net system and then had to rebuild it. And so we're still in that process of doing that, and whatever we can do to ensure that women have the coverage they need. Right now, we're only, Leslie, I don't know, the number I heard is it's 20 to 25% of women who are currently eligible are actually receiving the services based on the numbers that I was given. But the fact is, regardless, I don't know what number you would come up with, we know we're not seeing anywhere near the number of women who are eligible to receive this. Whatever we can do to expand it to where women are getting the services and they're getting the services they need is what we all want to have happen.
If I might just interject,
Please.
and perhaps Leslie can help me with this. One of the things that I'm proud of is that in Texas, as a result of what was done in the legislature and through the governor's office, is even after the onslaught of having to plug holes after the Affordable Care Act, in Texas, our numbers, the number of women that were actually served increased. When I was on HHSC Council, that was one of the things that was in front of us. So Texas did a very good job at serving women with the challenges of trying to expand the Medicaid program. Now, I may be wrong, but that's what my memory tells me, that there's a difference between eligibility and the actual number of women that were served. That's it.
And there's
Yes.
also a difference between the number of women enrolled and the number of women served, and sometimes those numbers get conflated, which makes it look
Yes.
different.
So if you're a woman and you're at 250% of the federal poverty level, which is approximately $30,000 or less a year, you can get services in Texas. There are several different programs that are offered to you. And I think one of the big things is there's been a lot of confusion over the last couple of years with all the changes and, what happened in 2011 and then trying to rebuild when we lost all the federal funds and then the programs changed. And so, it's been kind of like this roller coaster that everyone's been on. But I'll say that I think the stakeholders all came together, providers came together, and, this past year we've really been able to stay on the same path since 2016. And so we have these two new programs that have been revised. We're seeing a great increase in the amount of women being served from 2012. Whether we're at the 2010 numbers, we're still kind of analyzing all the data. Unfortunately, the data is different than the data we have today, and the way we calculate data is very, very different than what happened in 2010. Just kind of actually like the conversation we had today about maternal mortality, we calculate it differently, and we look and we do a much deeper dive today than we did back then. So, to answer Representative Howard, we're looking at it, we're still trying to make sure, but we are on the right path. We're continuing forward, and I think the most important thing is that the providers are really coming together and saying, these are the programs that our clients are saying they want, and having hypertension, having diabetes treatment, having limited postpartum depression, making sure that all contraceptions are available and that women can be able to access these services is a huge improvement, and that's a credit to the legislature and the governor for really driving that vision since the changes that happened in 2011 and 2012. So I think we're on the right path. But there's always more work. We need more doctors in Medicaid. We need more nurses. We need more community health workers. We want every single student coming out of med school to come and sign up to be a Medicaid provider, because that's where a lot of our clients are, and we want to make sure that we're offering the best services we can. So it's a lot of work is left to be done, and we're committed to making sure we're doing our best job and working together on it.
All right, thank you all.
Thank you. Sir?
Yes. Thank you for the discussion. Appreciate it. I had just one question, Leslie, for you, is whenever we talk about women's health in Texas, there seems to be two sides of it, at least. The medical services we provide and the social services we provide. We've talked a lot about the medical services with the Healthy Texas Women, the family planning program. When it comes to the other side, the social services, does the legislature need to invest more in programs like the Alternatives to Abortion programs, other programs that are dealing with social services, not just medical, which sometimes the legislature doesn't look at both sides of that?
And I think the legislature did invest a tremendous amount of money, which we're working to get out into the field right now. We're working very hard on that. I think that you do have two paths. You have the medical path and you have the social services. And what we've really been trying to do as direction from the legislature through the transformation of all the Health and Human Services Commission is say, let's bring them together. Let's say, let's
Right.
walk hand in hand, because you need the medical services, but you also need the social supports. You need the community to, really help a woman as she's on this journey. So I think one is not more important than the other. I think they both need to be alongside and being able to help a woman and help with children's health as well. So I think we're on the right path. I think there's still things that are happening, especially with the Alternatives to Abortion program, but it's it's being revamped, and I think we're about to see some great progress there in the coming months. And so I think it'll be really a decision for the legislature once we can provide all the data requested, that we can really have a better feel and be able to help inform where we are as a state and where we need to go in the future.
I would just say that with the limited resources we have, we do want to be strategic and make informed decisions about the best investment of the limited dollars we have. And one of the programs, of course, that I and others have been really supportive of is the Evidence-Based Nurse-Family Partnership, which has a real good track record of providing the kind of social services and support to the mother and the new family. So I think whatever we do, and I think we already are actually doing some of this investment, we want it to be in programs that have a good track record of showing what the outcomes are that we're desiring and making sure that we are demonstrating that we're achieving those goals.
Yeah.
I have to say, just in a simplistic sense, a semi-answer to your question, which is, I've always had a little bit of a concern that we separate them. Because if you think about it, nutrition and education before the delivery of the baby directly connects to the medical outcome of both the mother and the baby. So I have a little, I feel a little uncomfortable when I say, well, we got the social stuff over here and we got the medical stuff over here, because the social stuff very much impacts the medical stuff.
Thank you.
Yes, ma'am.
Well, thank you for a very informative discussion. And Representative Howard, it's good to see you again. And you and I share the same alma mater. I'm also a UMHB Crusader. So, and I've learned a lot. If we can go back to that first slide, I've got a lot of questions, but I'm going to narrow it down. But I noticed a lot of classifications under maternal mortality didn't make sense to me. For
You mean
example,
the list? Is that the
the list that we had.
The chart.
And how they would be, how do you classify what constitutes for maternal mortality? For example, homicide. And, it's a very high number. It's very alarming. So do you it doesn't look like you classify it as directly a pregnancy-related death. So I was kind of wondering, why you would include those things in there. And then why, are any of these preconditions? For example, did the mother have a precondition with a heart issue before pregnancy and delivery? Did she have a pre-issue to drug abuse prior or during pregnancy? So are all these things, are they looked at when you look into your research and your studies and your classifications?
So they look at each file individually and as much information as they can get, any of the like legacy primary health care visits that they can obtain from the doctors, or anything that happened during the pregnancy. So they do a extremely deep dive on the data, and really be able to say, what is her story? And where did we need to do something better and could have avoided this death?
Right.
So I think that it's what you're seeing here is the confirmed cause of death. So that's why we include homicide, which means that's where the family violence program can make a difference. That's where some of our education programs can really talk about, safe families, safe environments, and really making sure women know where to go if they are being abused. You have also issues like suicide, which could be postpartum depression.
Right.
And so,
Right.
okay, what do we need to do for education? It used to be a taboo word to say postpartum depression, and then it's something that really in the last couple of years we're being honest about.
Yes.
And I think suicide is a cause of death, and we need to say, where could we
preventable cause of death?
preventable cause
Right.
of death that Texans can say, where can we do better? How can we help? And so I think so we wanted to be honest as far as what were all the individual causes of death, but then there are some that are specifically medically associated that there are interventions that we can provide, and I think we can do that through the new safety bundles that we're implementing.
Right. I have written papers and even written the World Health Organization and the Secretary General to the United Nations that homicide is the leading cause of death nationwide to pregnant women. And it's normally the father of course, of the child who doesn't want to have the child, or the woman refusing abortion, is a high rate of homicide, which leads to my second question. Why isn't death caused by abortion-related causes listed under these things? Because I do know personally women who died from complications of a legal abortion, hemorrhaging, perforated uterus. One had a heart attack because the abortionist provided too much, whatever, she went into cardiac arrest and died on his table. So why aren't those listed as part of your research?
So I'll say all of this research is women who deliver the baby. And so since Texas does have the ban on 20 weeks for abortion, all of the abortion, any cause or effect related to abortion was not included in this data. But I know the legislature has directed the state agencies to look at abortion data. So I think that is something that we're undergoing right now.
Okay.
But that is separate from this list of maternal deaths. Specifically, this was women who went into the hospital setting and or were about ready to deliver. So it was a full-term baby that they were.
Okay, because I see while pregnant, so that didn't really specify whether she was going into delivery or during her pregnancy died.
Mm-hmm. So it's during pregnancy, but it's specifically the 20-week period, and especially with the abortion discussion, is not included in this analysis.
So we're going to include that, though.
So I think
It is
in
going
the
to be
future.
analyzed,
So I
but
think
it's separate.
there's a separate group that's working on that data.
Okay. All right. Thank you.
Yes, ma'am.
Are there any data that show what the comparison is as far as women who come in late stages of pregnancy across the border to give birth as compared to women who actually live here at the time they became pregnant? Is there any way to know how that impacts our figures?
I think that's a part of the deeper dive that we're doing. I don't know if that data is all. I don't believe that has been the analysis that's been released yet. We've mostly been focusing on maternal causes of death, but I think those are issues that I can share with my colleagues and see what we're looking at. But I think for most part we've been really focusing on the actual cause of death and not necessarily who the woman is, if she was from Texas or another state or another country. Really, why did she die here? What happened in her death?
What I can add to that is that when you look at the breakdown, demographically, the ethnicity, race of the women that are affected, we've already talked about the disproportionate impact on African American women. The Hispanic women have the lowest number of Hispanic, white, African American. So that addresses your question maybe to some extent. Also in the deep dive that was done with the 2012 statistics, there were, I think, I want to say 11, I don't remember the right number. There were several deaths that were taken out because they were from out of state, not out of country, but they were not Texans. So it wasn't looked at in any other way that I know of at this point in time, but those, what I've just told you may kind of inform a little bit of what you're looking for.
Okay, thank you.
We'll leave the last question
Okay.
to the physicians.
Thanks for a very lively discussion and analysis, especially the numeric analysis, which I know is really hard to get out to our general audience. But I see twice as many drug overdoses than I do cardiovascular events. For example, Dr. Hollier, who's the AIM chieftainess, and very courageous woman. She rebuked her own, the ACOG Green Journal. She reanalyzed that data, and that's important to analyze data, even when you say studies show, to reanalyze it and analyze it and see if there's something wrong with it. Now that's really great because it perked our ears up, but it gave Texas a bad name, so we looked a little harder, and that's very good. My question is twofold, kind of. First of all, if you don't go, you can't know. If a patient can't go to the doctor, then they don't know anything. And we talk about access. We usually talk about it monetarily and so forth. But for example, Texas had I believe a recent, might get the number wrong, 1127. It was a telemedicine access bill. Texas has X number of people, but we have this much geographic area, and physically patients can't get, and sometimes socially don't want to get too far away from where they live. I've had clinics in the hood, so to speak, and downtown, and my patients in the local areas don't even want to leave that area socially.
Right.
Part of us understanding how patients work is understanding how to get to them, and my question really, sorry about that, is how can we influence the real access, physical access? How can we influence the legislature to boost that up and make that available? That involves not just us as physicians, but payers and the legalization of a patient contact. Thank you.
Wow, okay.
All eyes
There's
on you.
a lot to that. I mean, I don't know that there's one answer there. Clearly, we have a lot of work to do to ensure access that's beyond whether or not we expand Medicaid, that's beyond whether or not we have insurance even, because insurance doesn't necessarily ensure access either. So to your question, I think some of the things that I think we would certainly want to look at is providers. And we know we have a shortage of providers in this state. We have a shortage of physicians. We have a shortage of nurses. We also have had limitations on ability to practice to the full
Yes.
Extent of your
Thank you.
education and training as an advanced practice registered nurse, which thank you for testifying about that. So, you know, making sure that we're getting the providers out there looking at telemedicine, looking at how can we use the technology we have to effectively deliver care? How can we use paraprofessionals to help us also provide greater capacity? You know, money is not always the answer, but certainly investing appropriately in our educational programs so that we are able to get more nurses and physicians through the education pipeline. We were talking about graduate medical education. We still do not have sufficient GME funding in this state to keep our medical students here when they're going into their residencies. Tuition assistance just across the board would be a big help there. Making sure that we're reimbursing in a way that encourages providers to participate in our programs. We reimburse at a rate that's pretty dadgum low, and a lot of providers are not able to sustain their practice by participating in our programs. So money is absolutely going to be an issue too, but I think it's not just what I've mentioned, it's those things and much more, but your point is well made.
I have to give some credit, or shall I say a 50% credit in response to Dr. Harris's question, which is I always saw one of the gains that we could make in access, the combination of huge state, right? The largest landmass, forget Alaska.
Yep.
And 29 million people spread out over this huge landmass. I always thought that the combination of telemedicine, which I think the legislature did a huge lift last session in releasing telemedicine, but the second half of that, at least for me, was the advanced practice nurses getting out into the rural areas or the underserved areas within our inner cities. The combination of the telemedicine, you can have a pregnant woman come, you know, in Raymondville Falls, population 9,500 and something, but if there's a telemedicine hookup and an advanced practice nurse,
Yes.
That pregnant woman can get good prenatal care.
Right.
Yes, ma'am.
I'm sorry, I
Last
didn't realize
word.
there's a time limit.
Yes.
So my question is, when educating the public on the family planning and contraception program, do you also disclose the medical programs available if she does become pregnant? And is pregnancy discussed in an honoring and respectful way where she would not consider it being something abnormal? You know, because we do want to make that change. That's what we're talking about today, in the way the women think in this country. And also, do you disclose about birth control and the risks on birth control?
Leslie,
I guess
that's right
Leslie's
in your...
program.
I guess it's me.
Leslie.
So, I think on all of our programs, you know, we follow, all of our providers have to be the medical providers have to be enrolled in Medicaid. And then they contract with us if they want to do additional services. So some of the programs are by contract only, or some of them are hybrid. And so in that, we outline that, you know, you talk about all the medical benefits that are available to the woman, whether she's pregnant or not pregnant, the different contraceptive available services for her and the benefits for those. And then, you know, like how she wants to, you know, she doesn't have to accept any of them. That's her choice. And so I think there's just a lot of, we encourage the use if a woman does not want to be pregnant and she wants to focus on her job, she wants to focus on something else, and she wants birth control, we encourage her to be able to receive it. But that's her choice if she wants birth control or not. But our job is to make it available and be able to make sure that we're abiding by the direction of the legislature and having the best programs out there and offering the array of services provided.
Okay, but do they also discuss about motherhood and, you know, programs that can help her during the motherhood?
Yes. So if she, again, with about 50% of all pregnancies being unintended, they also discuss, you know, if you became pregnant, here are some programs that are available for you.
Okay, I just wanted to make sure that, thank you.
Thank you. First, I want to, before we thank everyone, and I think they deserve a big round of applause. I won't do it because I'll hurt your... Thank you so much. Secondly, I do want to announce that next week, TPPF will host Jonah Goldberg for a book talk and signing of his new book, Suicide of the West. It's on Wednesday, May 9th, from 11:30 to 1. The bad news is that the event is currently sold out, but there is a fair attrition rate, and so I would encourage you to visit texaspolicy.com events and just register for the wait list. It's going to be a great event. And thank you, everyone, and thank you, our panelists, and good day.